afternoon, everybody. Today, in this instruction course, we are going to discuss diagnostic conundrums in cases of orbital inflammation. Most of the oculoplastic surgeons, if the general practitioners in ophthalmology, they come across orbital inflammation cases, we commonly call it a hot orbit. So many times there are diagnostic dilemma, management dilemma. So we would like to give you an insight about this diagnostic dilemma in orbital inflammation, how to manage these cases. Today we have with us a galaxy of oculoplastic surgeons from all over the country. I'd like to introduce Dr. Sripurna Ghosh. Dr. Sripurna, I'd like to please come here, the dais. Dr. Sripurna Ghosh from West Bengal, faculty of in a medical college in Kolkata. Joita Das, please Joita come and sit. Joita Das, she is a great oculoplastic surgeon. Most of you know her. She is working right now in Disha Eye Hospital, Barakpur and Kolkata. Next in panel is Dr. Anirban Bhaduri from Shushrut Eye Hospital. Anirban doesn't know any introduction. And Dr. Fairuj, I think she will soon join with us. Dr. Fairuj, I'll introduce her once she is in. And myself, Dr. Chandana Chakraborty from in a government medical college of Kolkata. Thank you. So I'll request Sripurna to start her presentations.
Thank you very much, ma'am, for including me in this IC. Today we shall be discussing on orbital inflammation. Just a minute, please. Yes, thank you. Yeah, today we shall be discussing on orbital inflammation. I will be taking you all through the anatomy and the location of lesions. Okay. I have no financial disclosures. Orbit is always known as the Pandora's box. So whether the orbit tells us a story or gives us a nightmare depends on us, on how we look at it. Now coming to the anatomy, we have the orbit which houses the globe and the periorbita. We have the superior orbital fissure in the apical region, annulus of Zinc, the LFT nerves, the vessels, and based on involvement of these structures, we have the superior orbital fissure syndrome and the orbital apex syndrome. The difference between two is the involvement of the optic nerve or not. Now, what are the questions that should always be on our mind when we are looking at a hot orbit? Where, when, why, and how? What are the signs and symptoms? Was there any predisposing injury or surgery? When is the onset? And where is the location of the symptom and the radiological localization? We will always find the signs of inflammation, whether it's infection or inflammation. Rootman has classified hot orbit in form of systemic inflammatory disease, which may be thyroid eye disease, Wegener's granulomatosis, neoplasm, which may be rhabdomyolymphoma, or any congenital lesions which have been secondarily infected or inflamed. And NSOID, the reason why I have put NSOID in the last is because it is a diagnosis of exclusion. Now, this 6 P's must always weigh on our minds: pain, proptosis, progression, pulsation, palpation, and periorbital changes. Now, keeping these things in mind, let us go through a few cases. This was a case. It was sent to us by Dr. Bhaduri sir. He was a 12-year-old male having recurrent swelling in the left eye, since the last over a few weeks. On imaging, we find an abscess. We had sent the sample after incision and drainage for culture sensitivity, and after a course of IV antibiotics and FES being done, he had recovered wonderfully. This man, he's 80-year-old. He had undergone cataract surgery a few days ago, and he presented to us with pain, proptosis, restriction of eye movement. So this was a case of panophthalmitis. This was a unique case. With, this patient had a history of gradual progressive painful swelling in the left lower lid since about a few 3-4 months. I was thinking on the lines of lymphoma. I had biopsied it twice because I thought it was lymphoma with a diffuse mass and around the orbit, which is in the orbit surrounding the globe, but it came out to be granuloma pyogenicum. This is of the COVID era. This lady had rhino-orbitomucormycosis and was treated mainly in the ENT department, and FES was done in there. Now coming to the inflammatory lesions. We all know this is a typical case of thyroid with mostly in the active form because of the congested eyes, the proptosis, and the fullness of the periorbital regions. They may also come with restriction of eye movement. It may be in the quiet form also. We know the antibody and the molecular mimicry which goes into the pathway of thyroid eye disease. Whenever we think of thyroid, we should always keep the Rundle's curve in mind. We should know whether it is in the active phase or the inactive phase. In terms of this, we have the activity score and the severity score. Recently, yesterday, I heard about a low-grade clinical activity score, which is less than 3. Now, this patient came to us about 2 years ago when he had a small swelling in the left lower lid. We can see a slight pinkish salmon pink appearance in the medial caruncular, in the medial region, medial palpebral region. We had advised for an biopsy, but the patient was lost to follow-up and then came again in 2024 end for a biopsy. This was a case of lymphoma. We can see the mass surrounding the globe, but not pushing it. Similar case, bilateral involvement of the orbital fat. Here the salmon pink appearance can clearly be seen in this man. Okay, these are the congenital lesions or dermoids which may secondarily be infected, or there may be a ruptured dermoid leading to a inflamed orbit. This girl, she was about 16 years old. She had an osteosarcoma of the right tibial joint, right tibia, and she came to us with a triradiate lesion, which is a neoplasm. I will not go to the diagnosis in detail, but I will just put certain things so that we know what to look for and where to look for it. Okay, this lady, what we assumed initially was a sebaceous gland carcinoma. Basically, it was a lacrimal gland carcinoma, which had presented with rapidly progressive swelling in the right orbit. I was not very sure about the diagnosis of this boy. This child, he had come to us with bilateral proptosis with a hemoglobin 5, HPLC showed HB rate. He was diagnosed as Erdheim-Chester disease somewhere else. His serum ferritin levels were raised, but we know that in Erdheim-Chester disease also, the child can come to us. It is a child can come to us with bilateral proptosis. It is a form of non-Langerhans cells carcinoma. Now, coming to history and examination, for trauma, we have to take a detailed history. There may be some incidents of trauma which may slip the mind of the patient. For infection, we should go for a blood culture and a CBC. But whenever we are thinking of an infection, we should always start with the empirical therapy, not waiting for the culture or the imaging. We can, for thyroid, we should do the thyroid profile. For lymphoproliferative diseases, we have the CBC, the imaging. For sarcoidosis, the ACE and the lysozyme assays. And for Wegener's, the ANCA and the PNS images, whether there is any destruction of the PNS. When all are ruled out, then comes the idiopathic inflammation. There has been many names, non-specific orbital inflammation or IOID, but it is benign, non-infections and often recurrent. In our population, thyroid comes first, then comes lymphoma, and then comes the painful orbitopathy or NSOID. The few common features are based on the location, anterior diffuse apical, myositis or dacryoadenitis. The uncommon ones are periscleritis, perineuritis, or focal mass. Always a diagnosis of exclusion. Now, as per the location, most common is the orbital fat, then the lacrimal gland, the insertion of the muscles, uh, and the optic nerve, and finally the sclera. A study was conducted by Swami et al., which showed that the lacrimal gland and the orbital fat are the most common parts to be involved. Coming to the differentials, it may be of NSOID, maybe myositis due to thyroid ophthalmopathy or orbital lymphoma or CCF. What must be borne in mind that thyroid ophthalmopathy is always bilateral, mostly bilateral, it spares the tendon. While in CCF, we can see the SOV, we can see the flow voids, we can go for an angio, and we can see the retrograde flow of the blood. Now, when we have a case of dacryoadenitis of NSOI origin, then we must always rule out orbital lymphoma, where we can see a palpable mass and we can see a trailing sign on the image. And there is diffusion restriction in orbital lymphoma because the mass is densely packed, and so there is diffusion restriction. The apical lesions include orbital lymphoma or metastasis or Tolosa-Hunt syndrome, which shows a waxing and waning progression. Diffuse inflammation in the form of granulomatosis or anterior lesions in the form of cellulitis. Now, a consensus diagnostic criteria for orbital inflammation has shown that painful red eye, orbital pain, and enlarged muscle tendon is present in almost 70% of the patients. The clinical presentation may be in the form of pain, proptosis, diplopia, with or without decrease of vision. We should assess the lid, the orbit, the extraocular muscle, and the optic nerve function. Systemic correlation must be dealt with by doing the blood profile and blood profile mainly. Yeah. This girl, she had a swelling in the upper eyelid. We had started with IV antibiotics and oral steroids, which subsided with time. Often in case of myositis, we can see the enlargement or the inflammation at the site of the muscle insertion, and the medial rectus is most commonly involved. There is often recurrences seen. There is no sparing of the tendons in case of NSOI. In dacryoadenitis, there is an S-shaped upper lid deformity. It may be associated with Sjogren or may run a chronic course over a period of time. Now, diffuse anterior variety may have a CT scan showing enhancement of the uveoscleral region, just as we see here. Or we can see the T sign. We can see the T sign as the last slide. In case of apical variety, there may be Tolosa-Hunt syndrome, the orbital apex syndrome, or cavernous sinus disease. The tramline sign is seen when there is involvement of the optic nerve. These are my references. Thank you.
Thank you, Sripurna. That was an excellent presentation. So many varieties of cases. Now I'll go to Dr. Joyita Das. Dr. Joyita, please. Dr. Joyita, Sripurna, as she has told that you can do USG, CT, or MRI. Now, Joyita will tell us what to do, in which cases, whether it is a case of CT you will do or an MRI you will do. Joyita, please.
Yeah, thank you, madam. I'd like to thank
Dr. Fairooj has joined us.
Yeah, AIOS Scientific Committee and Dr. Sadhana Chakraborty madam for this kind invitation. So I'll be talking on nuances of MRI and CT scan in orbital inflammation. Sripurna has already described that orbital inflammatory disease include a spectrum of conditions affecting the soft tissues of the orbit, including idiopathic orbital inflammatory syndrome, thyroid eye disease, and infectious orbital cellulitis. The importance of proper diagnosis and the timely diagnosis is, this thing is actually, it's a potential visual threatening and may require a prompt diagnosis so that we can do proper treatment. And there must be a differentiation from the neoplastic or infectious process. These are the gross classification of orbital inflammation. We can divide it into infectious and non-infectious. Among the infectious, we can divide it into infectious, infectious, and non-infectious. Infectious means the inflammation is present in the orbital area, and non-infectious means the inflammation is present in the orbital area. Infectious means the inflammation is present in the orbital area, and non-infectious means the inflammation is present in the orbital area. non-infectious, there are many types like systemic inflammatory disease, neoplastic, vascular, and idiopathic. And the diagnosis of orbital inflammation, these cases are mainly based on history, clinical examination, imaging of the orbit, and laboratory investigation. The imaging plays a crucial role in diagnosis, differences from the neoplastic condition. It determines the extent and severity of the lesion and guide us for the therapeutic approach, whether we have to go through medical treatment or we have to urgently go for any surgical treatment. The main investigation which is usually in practice, these are CT scan, MRI orbit, and USG B scan. However, USG B scan is very much technician dependent and operation dependent, and it's not always used in case of only it is used for some cases of suspected cysticercus or orbital abscesses, but it is not routinely done, so I will skip this. First, we have to know the planes of orbital imaging. We have axial imaging, where the scan has been done through the horizontal plane, which is also known as Frankfurt plane, which lies which is spreading from the orbital floor to the external auditory meatus. Next comes the coronal cut, which is the vertical plane, which takes the picture of the orbit from front to back. And last is sagittal section. It is also a vertical, cutting the tissues in a vertical plane, but from side to side. First come to CT scan and orbit. It has a crucial role for rapid diagnosis. It is important. The advantage of CT scan is it is rapid imaging, because in some cases like orbital cellulitis or orbital abscess, we have to diagnose the case promptly. So this CT scan is very much useful in these cases. It also gives superior bony details, like in this case with a tumor with a bone erosion or fracture or hyperostosis like fibrous dysplasia, etc. It also gives some good tissue contrast, like in case of thyroid eye disease, you can see the muscle bulk, belly, and also some fat strangling in active disease. First, we will go by the cases. In the key picture of CT scan, we see in orbital cellulitis is soft tissue edema. Both in orbital cellulitis, both the preseptal area and the postseptal area is enhanced. And the second point is loss of orbital spaces delineation. You cannot clearly delineate the demarcation of intraconal space, extraconal space, nerve, etc. Next point is strangling of intraconal fat. In normal normal orbit, you can see this black area. This is a normal intraconal fat. However, in orbital inflammation, especially orbital infections, there is some reticular pattern of enhancement. This is known as strangling of intraconal fat, and it is very much characteristic of orbital infection, cellulitis. Next is extracellular muscle edema. In severe infection, there may be the muscle belly is there is some thickening of the muscle belly because of fluid collection. One most important part of CT scan in orbital cellulitis is it detects the paranasal sinus mucus thickening and fluid collection, which are very common in orbital cellulitis, which needs surgical treatment. And subperiosteal and orbital abscess, there is collection of fluid under the suborbita, and in this case, these cases actually need urgent surgical intervention. Next is non-specific orbital inflammatory disease. Non-specific orbital inflammatory disease, already Dr. Sripurna has told that it may affect only the lacrimal gland, that is known as dacryoadenitis. In a classic lacrimal gland enlargement can be seen in CT scan. These are the enlargement of the lacrimal gland here in both the side. However, this may happen also in other diseases, like some tumors like lymphoma and other diseases. For that actual diagnosis, we have to go for MRI with some special protocol like DW1. Next is enlargement of the extraocular muscle belly with a tendon. This is myositis. Here you can see that both the muscle belly and the insertion is inflamed, enhanced. See, in thyroid orbitopathy, we can see the thickening of the muscle belly, but which spares the tendon. The muscle belly thickening, the order is, the most common is inferior rectus, medial rectus, superior rectus, lastly lateral rectus. Where is in another orbital disease, which is immunoglobulin GG4 disease, we see the lateral rectus is the most common muscle to be involved. This also can be detected in CT scan orbit. And in very severe activity score, we may also find, along with the muscle belly thickening, lacrimal gland edema. Next comes to the orbital MRI. It is the modality of choice in evaluation of orbital inflammation because it gives us superior soft tissue resolution which differentiates the inflammation from the neoplastic disease. It gives a better optic nerve and intracranial assessment useful in chronic cases and autoimmune diseases. But first, we have to know the protocol. This is the T1 weighted image, which is basically used for anatomical detail and structural assessment. Here, inflammation appears to be ISO or hypo-intense. This is than the normal orbital fat. This is the orbital fat, and this is ISO or either same or hypo-intense, that is less brighter. In T2 weighted scale, this actually highlights the edema fluid accumulation, and it is often seen as a hyper-intense lesion. In active inflammation, the structure shows it's very hyper-intense, that is very much brighter. And when there is chronic inflammation, fibrosis, it may appear as a hypo-intense because of less water content of the tissue. Next is post-contrast T1 weighted imaging. When there is a fat saturation, this enhancing lesion or inflamed tissue appear bright due to increased vascularity. So the pattern of enhancement differentiate between the inflammation and tumor. When there is inflammation, it is more homogeneous. When there is tumor or infection, it is usually shows heterogeneous. And then next comes diffusion weighted imaging. It's a special imaging pattern which shows the diffusion of the gadolinium contrast in the tissue. Here, inflammatory lesion will have less diffusion restriction, and because of the high vascularity, and will show high adhesive value. But in malignant tumor like this, there is higher cellular content which will restrict the diffusion. You can see this is the diffusion weighted picture. In the first picture, this is orbital inflammatory disease. This show high adhesive value, whereas the malignant tumor, this is showing the less adhesive value and low diffusion restriction. The first case is a 21-year-old lady who presented with swelling and on and off on 6 months. There is no systemic illness. She has no thyroid illness. There is mild proptosis. On examination, she has mild limited abduction, and there is a pain on ocular movement. On CT scan, we can see there is thickening of the medial rectus and lateral rectus belly with the tendon and post-contrast lacrimal gland enhancement. This is the post-contrast picture. Lacrimal gland is enhanced. So I did an incision biopsy, which came out to be a non-specific orbital inflammation. Patient treated with oral steroid, and now she is doing well. This is the second case. It's a 35-year-old lady. Both came with a upper lid swelling, both eye for last 1 year. She also has some dry mouth, foreign body sensation. Sorry. On ocular examination, the vision was normal, but there was both eye upper lid. There is diffuse swelling and, I'm just finishing. Mild erythema. This is the 9-gauge picture which shows restriction. So we differential diagnosis was Sjogren sarcoid IgG4 lymphoma, etc. So after investigation, all are normal except immunoglobulin GG4 level was raised. So on imaging with contrast, we see there is T2, there is hyper intense lacrimal gland, and one interesting thing is enlarged intraorbital nerve, infraorbital nerve. So my first clinical DD was IgG4 disease, did an incision biopsy, but there is a surprise, it showed a lacrimal gland infiltration with medium-sized lymphoid cell, and this patient underwent chemotherapy and now she is doing well. This is another case which presented with acute proptosis with dimness of vision. These are the disc picture you can see in the right eye, and in the CT scan you can see diffuse enhancement of the intraconal space, which is quite finely molding the globe. So I thought it could be a lymphoma, but it ultimately came out to be a IgG4 disease. This is the 6-month picture. The next case is a 30-year-old lady who presented with sudden pain and ptosis of left eye. And she has having inability to move eye in all gauges. In CT scan, you can see there is thickening and enhancement of the left cavernous sinus. This is the left cavernous sinus, which is extending also to the apical region. So the provisional diagnosis we made, this could be a case of orbital apex syndrome. This is the blood investigation is normal, except ESR was high, ANA was positive. So this is a case of Tolosa-Hunt syndrome. She responded very well with 3 doses of IV methylprednisolone for 3 days. So when to use which one, there is just a gross guideline. In orbital cellulitis, the first investigation should be a CT scan because it gives a quick and detects abscess and sinus involvement. In suspected idiopathic orbital inflammation, MRI is a better choice because it will give us a better soft tissue contrast, rule out, it also helps in rule out tumor. In thyroid eye disease, both CT and MRI is useful. CT give the extraocular muscle changes, and MRI is better for optic nerve compression sign. In orbital tumor inflammation, MRI with diffusion weighted imaging is very important, which differentiated inflammatory from the neoplastic lesion. And in Tolosa-Hunt syndrome, I just see it's MRI is the investigation of choice to assess the cavernous sinus involvement. So the take-home pearls is CT and MRI has distinct advantage, and their selection depending on the clinical suspicion and the need for soft tissue versus bony evaluation. CT scan is the first line imaging in acute orbital infection and trauma. However, MRI is preferred for orbital chronic inflammation, optic nerve involvement, and intracranial extension. Ideally, CT scan and MRI both complement each other in some cases, like some complex cases. Thank you.
Thank you, Dr.
I'd like
Joyita.
to invite everybody. Just a minute, so the last slide, please. This year, we are organizing OPAI annual function from September 19 to 21st in Kolkata, and I invite you all to join us. Thank you.
Thank you, Dr. Joyita. I have a question to you.
Yes, ma'am.
If in a case of TED, patient has come because all of you, both of them are coming from a government sector. Many times either CT is there, MRI is not there, like this. Which one you will suggest for? You said both CT and
both
MRI
CT
to be
and
done
MRI,
in TED.
but in CT scan is quite useful in these cases for early diagnosis because all patients cannot afford MRI still in our group of patients. So CT scan can show the muscle pattern is very nicely. So you can have, but when we're suspecting some apical compression is there, then we can do a
So in
MRI.
a case of thyroid eye disease, we can
first
go for the
CT scan first. Yes.
We will go for MRI if you see that there is
There
an
is some
compression at the
compression of
optic
this.
nerve head, then only we will go for apex of the orbit, then
Yeah, to look for apex.
to find out the muscle belly thickness. And Anirban is saying something. Anirban? Yes, please. Microphone, the hand mic.
Since we have ultrasonography there, we usually go for ultrasonography where the tendon is involved or not, or the muscle belly is involved. Then only we
Yes, that's a good approach. You don't have CT scan there. USG is a good approach. You can very handy in the OPD only you can do it yourself. Only thing is that you have to measure the thickness of the muscle very carefully, and for that you need experience, and you have to learn it thoroughly. Otherwise, it is difficult. What is the thickness and all measurement? But if you do it routinely, then you can become expert in that. Dr. Anirban is something.
About this use of
CT.
MRI versus CT in thyroid eye disease. So, like you pointed out, so CT scan is something that you can do quickly. You will get results very fast. You don't need to book time because MRI is a long procedure. That's why fewer patients are done on the same day. So when you have a situation like thyroid optic neuropathy, a CT scan actually serves the purpose better because all you want to see is crowding in the back of the orbit. You really don't want to see the inflammation of the muscles, right? So that is something when you have a situation where you want to decide, do I want to treat or not treat the patient with systemic steroids, there MRI is more useful. But when you have vision loss in a patient with thyroid disease, CT scan serves your purpose because you are able to prove the crowding in the apex even on a CT scan.
Yeah, exactly. Thank you, sir.
Okay.
So thank you, Dr. Joyita, for
Thank
the
you.
excellent presentation. Next, I will call upon Dr. Anirban Bhaduri. He is from Shustrut Eye Institute, Kolkata. Anirban will talk about the malicious masquerades because already from the Sripurna, Joyita, all of them, they have discussed some cases, how will you differentiate between these various types of hot orbit. Some more insights from Dr. Anirban. Dr. Anirban, please.
Thank you, Professor Chakraborty, for allowing me to participate in your instruction course. So far what has happened is we've talked about different kinds of orbital inflammation. Dr. Shivpurna showed us a variety of cases where you have both inflammation from benign causes as well as, my slides don't want to come once. And Dr. Joyita so nicely told us when to do a CT scan, when to do an MRI, along with case examples of different kinds of inflammation as well as certain masquerades. So I'll just go on to masquerades. This is more of my line of work. And I have nothing to declare. Okay, so as Shripuna pointed out in the beginning, you have typical inflammations because of infection. So whether it is orbital cellulitis or fungal disease or a parasitic infection, they present with inflammation. We are all familiar with the 5 points of inflammation, which is redness, increased temperature, etc., etc. But this is actually a patient of orbital cellulitis, acute presentation. All right, but then you can also have more chronic inflammations. So other inflammations, the common being thyroid eye disease, that can present acute, but it's usually a subacute or a chronic presentation. And you have the non-specific and specific orbital inflammations where biopsy actually helps to prove whether it is one or the other. And they often present as a subacute or a chronic inflammation. Then comes the third entity. This is what we are all afraid of because this can kill the patient. Of course, some specific orbital inflammatory diseases can also kill patients. So if you have sarcoidosis, which is left untreated, you have vaginous, which is left untreated, that too can kill your patient. So it's important to know when to go and do a biopsy and then treat. So where does tumors come into the picture? Now, tumors, if they're rapidly growing, or if tumors have internal necrosis, these are situations which produce the inflammation that can often mislead us. And which is why we need to be aware of which are the situations where we would want to do an incisional biopsy and treat accordingly. Now, tumors in the orbit can either come from orbital tissues themselves or from surrounding tissues like the globe or from the sinuses or it can also come from a distant location, which would be known as a metastatic tumor. Let's look at example. So this is a 4-year-old boy presenting with a rapidly growing swelling in the upper lid with some amount of tissue prolapse, and the temperature is raised, there is erythema, but if you look at this close up, you will see that there are dilated blood vessels over the surface. This is not what you see in a typical orbital cellulitis. Again, in orbital cellulitis, it's very difficult to open the lids. The lids become very tight because of the edema. Here, the lids are not able to open because of the mass effect. And these are the scans which shows localized but very extensive lesion where you cannot find which is not well circumscribed. So you cannot go and remove this tumor in toto. All right, so this patient underwent an incisional biopsy and this is what turned out. This being the commonest primary malignant orbital tumor in children. This is another girl who was about to give her class 12 boards. She's older, she's 17 years old, again with a rapidly growing swelling. The entire history is only 3 weeks. And you can see the congestion as well as the inflammation in the ocular surface, not so much over the mass lesion itself. If you look at this, you'll see that you cannot really see the lateral rectus muscle. So there's a very large, well circumscribed mass. However, you cannot separate it from normal tissues of the orbit either. Now this patient went an incisional biopsy. This is an older patient, also turned out to be a rhabdomyosarcoma. Both these patients are survivors. Okay, so this was the third one. This is a 14-year-old boy, sick patient. This swelling happened in 2 weeks. Okay, what is your diagnosis? Same location, superior orbit. The globe is pushed down. We're not able to see the fundus in the left eye, but the right eye fundus was normal. Of course. Most likely. Could be. Alveolar sarcoma would be slower growing. So I'll tell you what happened. We posted him for an incisional biopsy the very next day. Okay. Feroz.
Was he anemic?
Look at the picture.
Yeah, so granulocytic sarcoma is another thing that we should think of.
Yeah. Look at this. This is the buffy layer, which is a thin layer over the
Oh, you have a picture.
deposited
now.
red blood
Yeah,
cells, and that is separated by plasma. So you have plasma and then the buffy layer and this. So this was a shock. In the evening, we got his hematological reports. And as you said, that this was a granulocytic sarcoma.
Yeah.
So this was, this patient actually had leukemia. His blast cells were around 90,000. Okay. All right.
Maybe there is ecchymosis because it's like this. We are
Yeah.
not able to identify. Yeah, right.
I
ecchymosis.
actually thought this was a rhabdomyosarcoma until I was proved wrong.
Yeah.
Okay. Now this is a patient who was referred as a allergic conjunctivitis oblique NSOID. All right. And you can see the little bit of congestion in both eyes. You can see a little bit of fullness in the upper lids. But when you palpate, we found that there was a rubbery lesion. All right. We sent him for a CT scan, and you can see bilateral superior orbital masses with areas of hypodensity. And this is the easy part. You have the diagnosis. So he gets dilated, he comes back from the CT scan. CT scan takes 5 minutes. He comes back dilated. This is what you see. Peripheral blood proves that he has leukemia.
And Dr. Anirban, the subconjunctival hemorrhage.
Hemorrhage, yes,
Yeah,
both
right.
eyes.
Yeah, right.
Yes,
Yeah.
that is the clue. All right. Okay, this is a lady who had orbital inflammation. She was given intravenous methylprednisolone, and the swelling kept coming back. So she was referred to us. She was losing vision in this eye. All right, the problem was because she was on steroids, we had to put her off steroids for at least 2 weeks. She came back with this swelling once we stopped her steroids and went ahead, and this is her imaging. So you can see the mass lesion which is surrounding the optic nerve, very prominent proptosis, and we did an incisional biopsy, and this is a bad one. So this is a diffuse large B-cell lymphoma, which is an aggressive lymphoma. This patient eventually went on to lose vision in that eye, although she survived the disease. Okay. So this was a patient. This is from my fellowship days. All right. This was a patient who presented with the orbital swelling. There is puffiness of the cheek, and you can see that he's got mass lesion in the orbit as well as in the sinuses, and he worked as a gardener, and he underwent a transnasal biopsy, and it proved that he had a fungal infection. He had hyphae there, but he kept getting worse on antifungals. Okay, so we went ahead and did a deep orbital biopsy, and this turned out to be a very aggressive lymphoma. This was a natural killer T-cell lymphoma, and this patient died about 2 weeks after the biopsy because of CNS manifestations. Okay. Okay, you see this congestion. This is a patient of thyroid eye disease. You see that congestion here. You see a bit of thickening of the the lateral rectus muscle.
More than a congestion, no? Focal. Yeah.
You are an ocular oncologist. This is not fair. But see the thickening of the tendon,
Yeah.
right?
Yeah.
And
the vessels, yeah.
this too was a lymphoma. So we did a biopsy from the conjunctival lesion here and a part of the muscle. This too was a lymphoma. Okay, this patient presenting with exposure keratitis with a lot of chemosis, but the scan shows that there is a mass lesion in the
Glandular.
lacrimal gland.
Yeah.
Okay. And is there anything else you want to see? Okay, I'll show you the bone windows. Do you see something here?
Yes.
Yeah.
Intraosteal.
So you see the periosteum getting stripped off the bone.
Yeah.
So the tumor has actually crossed the periosteum into the bone, lifting it up. This is an adenoid cystic carcinoma. Although it's a very well circumscribed lesion, there is no obvious bony erosion in this at this point in time, but it's already started invading bone. Okay, this was a patient we had seen, and patient lived closer to the Odisha border. So he would rather get treated in Bhubaneswar, and our colleague Dr. Devjyoti Tripathi saw him there. Presented with typical inflammation and lack of eye movements. And on histopathology, this turned out to be a mucoepidermoid carcinoma of lacrimal gland, which is a very rare tumor.
And this actually, if there is a temporal lesion, the eyeball should be dystopic.
Yes,
medially, no?
yes,
Yeah.
yes, yes.
That's
So these are
because-
not the entire scans, unfortunately. Huh. Okay, this was a very strange case. She again was referred while on IV methylprednisolone because she was not responding well to it. And her scan is very interesting. Okay, what is this? This scan is very typical of a particular type of
Yeah.
disease.
Fluid levels are there.
Huh? Fluid levels. This is typical of macrocystic lymphangioma or lymphatic malformation. The problem is that she never had past symptoms. She's 74 years old. The presentation was with pain, proptosis. All right. And a little bit of bleeding that is there. So we did what we would normally do. We aspirated.
There's no history of a proptosis.
She's never had a past history of proptosis. Okay, there was never any past history of any changes with upper respiratory infections. What you would expect in a patient with typical lymphangioma or lymphatic malformations. We did an aspiration, so we aspirated all the fluid, and the proptosis went down. And on cytology, they said that there were malignant cells. All right, so the swelling came back within 2 days, and then we went ahead and did an exenteration for her. This was an angiosarcoma. Very shocking. So normally, this is the picture we expect with a lymphangioma. Okay, this was another patient.
Venolymphatic malformation, we should have thought about it because there is no history.
Yeah.
Because in a venolymphatic malformation, we'll always have a
Past
childhood
history of any
Correct,
kind.
correct, yeah.
So typical vaccine meaning every time you catch a cold, there'll be a little bit of swelling. There might be a little bit of subconjunctival hemorrhage. All right, sometimes it is more severe, but that is how they usually present. So this was another patient presenting with chemosis. The eye is closed. She's already lost vision in this eye. All right. And if you see the scan, you see this peculiar dumbbell-shaped thickening of the extraocular muscle. Massive thickening.
Systemic evaluation.
Systemically, I'll tell you what was the situation. She was in so much pain that she was vomiting. There were no systemic lesions per se, but she was in dyselectrolemia. So we had to correct her dyselectrolemia, then get her up for a biopsy.
Oh.
And this turned out to be a tumor that I had not encountered before. So this was a inflammatory myofibroblastic tumor. This patient again underwent an exenteration and she's a survivor. Okay, it's a locally aggressive malignant tumor.
Will radiation help?
Yeah, so she was given EBRT. EBRT is known to...
But exenteration is must. Maybe
This patient, the swelling came back in 3 weeks.
3 weeks.
It's supposed to respond to steroids.
Yeah.
She seemed to respond, and then it came back very rapidly. All right. Another patient of orbital cellulitis, right, who needs to be given intravenous antibiotics as well as steroids at the right time. Is there anything else you want to do?
Imaging.
Sorry?
Imaging.
No. Blood counts, yeah, blood counts are normal. High, as a matter of fact, the blood counts are raised. The neutrophils were high. Anything else you want to do? Something you have?
Systemic evaluation.
Systemic evaluation, no, nothing else in the body. Anything else? Anything you want to do? Imaging, what kind of imaging? You don't have a CT in your hospital.
X-ray.
Ultrasound base scan.
This was in case of retinoblastoma.
Yes, so you have a B scan. Every patient, every child presenting with an orbital inflammation, please do a B scan. All right.
Orbital.
Apart from all the other strange manifestations of retinoblastoma, where we would want every child who's going to undergo an intraocular procedure, whether it be a cataract surgery or a hyphema drainage, please do a B scan. Most likely you're going to find something like this. All right. Okay. This is another patient presented with swelling. Again, Feroz will tell me that, the eyeball has been displaced up, so where is the mass lesion? So this is the most anterior section I found of this. I was also intrigued. Why was I seeing a scan where, it's also, the globe is actually rotated upwards in this patient. Okay. And on biopsy, this turned out to be signet cell carcinoma. And the primary was in the GI. This was my first incisional biopsy when I returned from my fellowship and initial work in Hyderabad. Okay, what is important is something that Shripurna had talked about. The swelling, the temporal fullness, all right, which again shows up as a tri-radiate lesion. This is the trigone of the orbit. And so you have a mass lesion which is in the orbit, which is there in the temporal fossa as well as in the cranium. And what I was stupid because I did a biopsy. What I didn't see was I didn't see a throat. So we were, very modest. We were not very comfortable examining women thoroughly. And this is what we missed. If I had known earlier, we would have picked up the papillary carcinoma of thyroid much earlier. So just to summarize, I am in time. That orbital malignancies may masquerade as inflammatory disorders. What you need to have is a high index of suspicion and good imaging. And have a low threshold for incisional biopsy. So most biopsies may pick up non-specific inflammation, great. Specific inflammation is good, but sometimes you might pick up malignancies as well. And those are the patients, if you intervene on time, you can actually save them. Thank you. And everybody is welcome to join us in Calcutta for the next Oculoplasty Association conference, which is in September this year. Thank you.
Thank you, Dr. Anirban. It was such interesting series of cases. I'm sure it was, enlightening in every aspect. May I now request and invite Dr. Chandana Chakrabarti, who have curated an amazing instruction course for us. She's the chief instructor, and she will be talking to us on certain interesting cases. And I think even as a practitioner, we learn from each case. More than attending didactic lectures, something I really look forward to in any topic is learning from each different cases, and it teaches us a lot in diagnostics, as well as management protocols. Over to you, ma'am. Thank you so much.
Thank you, Dr. Fairooj. I want to be it an interactive session. This was a 43-year female who came with diplopia, lid swelling for 2 weeks with mild pain, dimness of the vision in the right eye, finger counting, visual acuity in the right eye with RAPD, extraocular muscle restricted, disc edema. So clinically, what do you think? What it could be? So this is the MRI picture. The muscles are enlarged. All the recti muscles are enlarged. Look at the lab investigations. Sianka is positive. What it could be? So it was a known case of GPA actually. And the patient was on systemic steroid and azathioprine for 8 years. Still the patient is having this type of symptoms and signs. So how we can manage this type of cases? When the patient is already on systemic medications. So we treated the patient with pulse steroid for 3 doses and rituximab also started. Because rituximab will take some time for action. So by the time pulse steroid did wonder. So if I see this patient as during the COVID time, she sent this video from her home only. It has come back nicely. So the final diagnosis is orbital apex syndrome in granulomatosis with polyangiitis. Orbital apex syndrome in the case of the GPA can occur because either the granulomatous orbital mass, compression effect, or it could be because of the small vessel vasculitis causing optic nerve vasculitis, and that causes this loss of vision. So the standard treatment for severe GPA is to induce the remission with immunocompressive such as rituximab or others in combination with high dose of corticosteroid. Scenario 2, 23-year female who came with bilateral recurrent swelling of eyelids, ptosis, proptosis for last 3 years. The swelling, itching and pigmentation of the right cheek for 2 years. There is off and on treatment with oral steroid during the recurrence of the disease. The swelling was non-tender, granular fill. There was regional lymphadenopathy. The anterior posterior segment NAD, Sarma test was NAD. So what it could be? This is something new. I didn't know at that time what it could be. So this was the lab investigation. There was high eosinophil count. Serum IG was high.
Miculix, ma'am?
No. This was the, Miculix is a differential diagnosis definitely. So you can see the MRI, hyperintense bilateral lacrimal gland, all the muscles are enlarged in both the eyes. So final diagnosis came from the lymph node biopsy.
Kimura's, yeah.
It was a case of Kimura's disease. Oral prednisolone we started and we tapered the dose and we had to continue the oral prednisolone for 1 year. The patient improved, but she again came back and after that we started azathioprine and she's in maintenance dose. She is doing well now. So this was the follow-up 2 months. This was the case which we reported in IGO also. KD is believed to be an allergic or autoimmune response to an unknown stimulus. The differential diagnosis, as you told, that it could be a case of TED, it could be a Miculix disease or a Hodgkin's disease also. But most close differential diagnosis is angiolymphoid hyperplasia, which actually the similar picture, eosinophilia is there, but the normal Ig is there. In KD, the Ig is, level is high. And also in HP, you will see in LHA, vascular proliferation of endothelial cells. KD may be associated with renal function. So the important thing is that these systemic investigations and the close follow-up of the patient for long term is very much needed. The patient, if the patient, you have to send to nephrologist. If it's a minimum symptoms and signs, then you can do observation. Medical treatment like in form of cetirizine, corticosteroid, cyclosporine, retinoid also has been advocated. In case of recurrent attacks, intravenous immunoglobulin has been advocated. Surgery, if it is an isolated lesion, large lesion, surgery can be done. And in recalcitrant cases or in large case tumors like swelling, can go for radiotherapy. This doesn't have, this is a good thing, this doesn't have any malignant potentials. So coming to the next scenarios, 18 years female who came with bulging of the eyes with mild pain for last 3 days. The patient gave an history of fever, headache, vertigo, stuffiness of the nose 1 week back. History of similar attack 8 months back. Extraocular muscle restricted movement. There was congestion of the eyes, episcleritis, interstitial keratitis. As you can see, the interstitial keratitis is actually at the periphery, along with submandibular lymphadenopathy. This was the CT picture. CT picture is showing lacrimal gland enlargement and the fat plane obliterated, as you can see. So I thought it could be a case of GPA, but no, it was not a case of GPA. Pianka was negative, though in 80 to 90% of the cases, Pianka positive in case of GPA, but 10% cases of GPA may be Pianka negative also. So finally, we diagnosed it as the patient had a conductive auditory deafness, which the patient was giving a repeated history that I can't hear. We started the patient on high-dose oral steroid. So clinically, we diagnosed it as a case of typical form of Cogan syndrome. Cogan syndrome is an autoimmune disease. It appears with all this may be typical or an atypical. In a typical case, as I told, this could be a typical case. So all these lesions features will be there. In atypical cases, this conductive auditory deafness may appear 2 years later. So this was the picture, final picture. As you can see, the patient is doing well with this disease only. There is a, we could not do any biopsy or as the patient improved and she didn't come for follow-up. This was a 50 years male who came with redness and loss of vision in the left eye for 1 month. Visual acuity, PL was denied as I told, RAPD, EOM restricted, disc edema. You can see the MRI picture. There is a hyper-intense lesion. All the muscles are enlarged in the left eye. It has extended up to the orbital apex. So that is most probably the cause of the PL negative patient. Lab investigations were not very suggestive. We did started with pulse steroid. Patient's visual acuity didn't come back, but otherwise the patient's signs and symptoms are decreased. So in this case also we diagnosed that in a case of orbital apex syndrome, idiopathic orbital inflammatory disease in OS. Scenario 5 actually, 30 years female. She came with swelling, mild pain, 2 days right eye. In other unit people, they started the treatment with as a case of orbital cellulitis. But there is not much of pain, mild pain. There was no systemic history. But she told that she had a similar attack 1 year back. Visual acuity, extraocular muscle, normal. Investigations, the only thing is that we, in investigation which we found, serum IgG4 level was very high. We started the patient on prednisolone in tapering doses. In MRI, you can see in the CT scan, there is bilateral lacrimal gland enlargement. After starting the prednisolone, the patient improved. But in this case also, patient didn't come back. So it could be a case of IgG4 orbitopathy. We can discuss later on at the end of our presentations. Another case, proptosis bilateral with lacrimal gland enlargement, lab investigations negative. Look at the MRI pictures, the muscles, the nodular enlargement of the muscles. In this case also initially we thought it could be a case of Wegener's, but it finally we diagnosed it as a case of idiopathic orbital inflammatory syndrome, because this type of the MRI picture, the muscles, they are more seen in case of IOID. This was the last follow-up when the patient came. 32-year female came with a swelling erythema in the lower lid. There is a history of trauma by a palm tree branch 3 years back. The patient was conservatively managed outside. This was during the COVID time. So she came to us with this picture, what you can see. And we did the CT scan. In CT, there is a linear hyperdense shadow you can see. Looks like a foreign body. So what we did is that we just directly we went for the see. Initially there was no foreign body we could found. The foreign body was totally encapsulated. We had to cut the capsule and then we took out the foreign body. So this type of cases also come with an hot orbit or inflamed orbit. So I'm not showing this now, how to proceed for a diagnosis of an inflamed orbit. These are my references. These are my team in various medical colleges. So to treat a case of inflamed orbit, don't burn your finger to treat an inflamed orbit. Thank you. So our last speaker of the session is Dr. Fairooj. Dr. Fairooj, I don't think she needs an introduction. She is a scientific committee member of AIOS, and she's now attached in Horace Eye Hospital in Bengaluru. Fairooj, please.
Thank you so much, ma'am, for having me here. Such a wonderful session. And as you rightly concluded that, we often burn our fingers in orbital inflammation. It's really not easy to control orbital inflammation. It's often tiring for the patient as well as the treating doctor. But now, fortunately, we have various, we have identified the pathways of inflammation, and we have biologics and various other drugs which is available, unlike the past. So maybe slightly it's becoming easier as a practitioner to kind of, tackle these diseases in the orbit. Yeah. Okay. So ma'am has given me the responsibility of, addressing various treatment modalities in orbital inflammation, and so far we have had very good case discussions, and we have definitely got some insight on that. My slides are not moving. Okay. Side view, yeah. So this is a young girl, a 12-year-old child who presented with this bilateral swelling, which was kind of diagnosed as bilateral preseptal cellulitis. In fact, possibility of a chalazion or an severe MGD, but that was not the case with this child. She had severe photophobia. As you can see here, there is tearing that is happening. That means there is some amount of, uveal component, and of course in slit lamp biomicroscopy, she had bilateral uveitis. So this was a case of an anterior IOID associated with tendinitis and anterior uveitis, where the child presented with photophobia, pain, and periocular swelling. Well, started with oral steroids, and this is how we deal with an orbital inflammation, whether it's anterior, posterior, or anything else, where we call it as non-specific orbital inflammatory disease to start with. Everything was happy, but then, we are also faced with challenges where any time this can recur. She had a recurrence. When she had a recurrence, her right eye was fine and silent, but she had a recurrence in the left eye. And then I went ahead doing an intravenous methylprednisolone for her, and she got stabilized with that. So any orbital inflammatory disease, I would say the first line of management is steroids, whether it's oral steroids to start with. I found in a child, possibly I would start with an oral steroids to be on the safer part and then go in for IVMP, because even parents were not really willing to go for an IVMP as a primary management, and she settled down. So this is kind of a chart that I have put in here, where whenever you get a typical case of NSOID, and it's just not patients walking into an oculoplasty, clinic. It can be in any general OPD that the patient starts with. So oral IV corticosteroids, pulse therapy, this is how we start with. And then if there is a rapid and a sustained response, which is well tolerated, then we taper over 6 to 12 weeks. Now, if there is an inadequate response or recurrence during taper, biopsy is definitely advised. If it's a non-specific inflammation which is not responding to steroids, then we go to systemic immunosuppressants like azathioprine, mycophenolate mofetil, methotrexate, and rituximab. I will be taking you to the detail. This is just a chart that I wanted to put up so that you can get an idea. And if we have any specifics, then you have to look for systemic disease and then further go ahead. Now, if the steroids are poorly tolerated initially itself, you can think about intraorbital steroids. Low-dose radiation is suggested in textbooks and literature. I don't use it much in orbital inflammatory disease in my practice, and of course, systemic immunosuppressants. So these are the treatment modalities again, the first line treatment modality, and I would consider the steroid sparing agents or immunosuppressants as a second line treatment modality, because the acute inflammatory control is much superior with intravenous methylprednisolone, and then you get a sustenance, and then you induce the immunosuppressants with either methotrexate, mycophenolate mofetil, or rituximab, and then we do have biological agent as the third line treatment modality. Now, talking about rituximab therapy for refractory orbital inflammation, we do use it. Personally, I use it in a very desperate situation when there is recurrence as a third line treatment modality, not as a second line. We see a lot of IgG4 disease. I use it for IgG4 disease, refractory orbital inflammation, and refractory Rosai-Dorfman disease in my practice. Protocol is injection rituximab is given 1000 milligram. There has been a study where they compared the regular dose and a low dose of 500 milligram, where they have not found any significant difference in the outcome. So, a low dose rituximab can also be considered. It is in sessions, so it is A and B sessions. So the day 1 you give, and then you call the patient either at day 14 after 2 weeks or 15, and then a second dose is given 6 months later, which is 24 weeks. So this is the protocol. Now, this is a very interesting case where the child has had a myositis prior, and then she was on oral steroids. This is a prior MRI before referring to me, history of myositis in one eye, and then she was put on oral steroids. Then she got referred to me, and this is how she landed up. Okay, it's not playing. Sorry. Second. Well, this is basically post-treatment. In fact, when she was referred to me, she had multiple muscles bilateral involvement, where it is a recurrence, and multiple muscle involvement. Well, so we went ahead with IVMP 6 cycles, 4.5 grams, and also put her on methotrexate. Now, how did we choose methotrexate? I have an amazing rheumatology team with me in my practice, where definitely I take their opinion regarding the immunosuppressants that is suitable for pediatric age group and adult age group. So in most of our scenarios where it's about a pediatric age group, we find methotrexate as a safer option. Orbital myositis, when we talk about, it can be idiopathic and it can be related to systemic and local conditions, and these are the muscles that can be involved, even single muscle or multiple muscle. This is a very interesting case where, in fact, we became a family, and, this journey has been going on for the past many, many years. It started from 2017, 22-year-old, he's a lawyer. Myositis, every time he gets a different muscle. Initially, it was thought to be a thyroid eye disease, referred as a case of thyroid eye disease, but then the muscles were waxing and waning, and he had all the symptoms of an IOID, and then a biopsy proven. So there were multiple recurrence at different aspect. He was tired, I was tired. Started with IVMP. We gave him azathioprine. I tried intraorbital triamcinolone acetonide twice. Again, it recurred, in 2019. Then I tried intraorbital rituximab for him. Although I didn't step to the second line DMRDs or immunosuppressants, but finally, we had to land up with mycophenolate mofetil, and so far he has been extremely, stable with mycophenolate mofetil. In fact, we wanted to start mycophenolate mofetil earlier, but then he's a very educated guy, so he was kind of worried about immunosuppression, and it goes on for a long time, at least 18 months to 24 months. So he was kind of perplexed whether I should be put on immunosuppressants, but finally we put him on mycophenolate mofetil, and he did well. 45-year-old lady, swelling of left eye, 1 month, painless gradual progression. And as you can see here, this is a lacrimal gland swelling. She has got an S-shaped ptosis over here, a large lacrimal gland in the left. In fact, she has a swelling over the other eye also. So when we talk about these lesions, either when it recurs or when something is really, really extraordinary, where, the connecting dots has become difficult, this is how we go ahead doing a biopsy. It's an incision biopsy in all these orbital inflammatory disease that we do when, your treatment modality with steroids has failed. So this was a case where we went ahead doing a biopsy, gentle, dissection of the tissue, and that is the septum that is being opened over here. Gradually you go for a blunt dissection, open it, and then you can see the lacrimal gland popping out. I just wanted to show this video because I just wanted to show you how we take the biopsy. And when we take the biopsy, we take at different level. We take superficial, deep, and deepest. Lacrimal gland, this is enlarged, so it's good to, we get ample tissue. In fact, I send it for pathology, and in certain scenarios, I also send it for microbiology. And in this particular patient, I sometimes keep tuberculosis in my mind, and genetic PCR for TB was also sent. Now, what we got was a non-caseating granuloma. The genetic testing for TB was negative, AFB was negative, Manto was negative. Chest X-ray was done, and she had hilar lymphadenopathy, and this was case of a systemic sarcoidosis. In sarcoidosis, I do have a series of orbital sarcoidosis presenting in different ways, even extensive orbital involvement, muscle involvement. So oral corticosteroids is something that I prefer, and these patients are put on low dose for a prolonged period. Vaginous granulomatosis with nephropathy, as ma'am had already shown, GPAs and vaginers, although they are on immunosuppressants, they can still have, severe inflammation recurring in the orbit, and the treatment of choice is definitely immunosuppressants, and rituximab can be considered in these cases. I had presented this case in the morning also in another orbit session. Interesting case of a 50-year-old gentleman, pain and redness right eye, 2 years, proptosis 6 months, diminution of vision 1 week. Clinically, I was so sure that this could be a case of a lymphoma because of the salmon color appearance in the conjunctiva. This is radiology, extensive lesion through the entire orbit. I went ahead doing a biopsy from that lower area, and this is a storiform pattern which was seen. His IgG4 levels were high, and this was a case of an IgG4 disease. Although it was an extensive disease, I started with oral steroids, intravenous methylprednisolone, and azathioprine. He got stable with these. I didn't have to step up any second-line management in that. But in contrary, this was another patient who was already biopsied elsewhere and diagnosed as idiopathic orbital inflammatory disease. He came to me, got referred when he had when his vision dropped as 6/60, when he had lesions in the fundus as well, and there was this large enlargement of the medial rectus which was compressing the optic nerve. This is like a recurrence after a previous biopsy was done, and I was not too convinced about the biopsy report, where there were no detailed histopathological evaluation done. I went ahead doing again a biopsy, and this also came out to be an orbital IgG4 disease. But despite the IVMP that I gave him, oral steroids that I gave him, he developed an orbital apex syndrome after stopping the intravenous methylprednisolone, and the disease was progressing in a very, very severe way, where an oral mycophenolate Morbital was started, but when he started becoming better, he became very non-compliant, and then the disease recurred again, and finally he landed up with a third line of treatment with injection rituximab, and he's doing fine. I'm not going into the detail of IgG4 disease because the time is
Yes.
running short. 20-year-old student, this is best corrected visual acuity 6/60, severe dacryoadenitis, recurrence, and when it recurred again, I saw that there is a bony erosion over here. It was at that time I went and did a biopsy for her. Well, she came as quantiferon gold test tuberculosis positive. I discussed with my seniors, whenever there is a bony erosion, what are the other things that I should think of if it's really not responding with anything else. And with opinion from the physician, what we did was we also started ATT for her, although there is controversy that quantiferon gold test, but she definitely did well, and there was no recurrence for the past 6 years in her. 48-year-old lady, complained of watering, 4 months, swelling eyelid.
Dr. Fairooj, I think we are running
We are
late.
stopping it. So I just wanted to show this. We thought she had a septal perforation. We thought it's vaginous granulomatosis, and this was a lesion taken. This came out to be natural killer T-cell lymphoma. So biopsy definitely can reveal the mystery. It is very, very important. So, conclusion is treating orbital inflammatory disease. Specifics has to be, considered. Never think it's non-specific. Most of them are specifics. So, this is my conclusion slide. Systemic steroids is the popular one. My favorite is intravenous methylprednisolone. I like azathioprine, MMF, and methotrexate. I dislike cyclophosphamide. And my last resort is injection rituximab. Thank you so very much.
Thank you, Dr. Fairooj, for the excellent presentation. I think in the interest of time, we can't discuss. We have already done a lot of discussion during our course, so we have to hand over it to the next session people. They are waiting, I think. Just have a group picture and we can't.